Why navigate? Well, I'll start off with showing you a couple of cases. This patient where surgeon put the tibial component in varus, in just 5 years collapsed further, needing revision surgery. Here is another patient where surgeon put the tibial component in mal position, early functional problem, and in 6 months I had to do the revision surgery. And there is enough literature, number of studies showing that if you have malalignment outside 3 degrees, you have poor function and rapid failure. Similarly, there are a number of studies which show that if alignment is correct, there is good function and better survival. This study done long back showed that survival at 10 years was much better if the alignment was within 4 degrees. Also, there are studies in total knee which have shown that good alignment leads to faster rehabilitation and better function. So really, in a total knee replacement, malalignment means problems and proper alignment means better results. And the quest for alignment is long. We started doing the total knee replacement freehand in 1960s and quickly realized we need mechanical jigs to improve the alignment, which have over the period of time been refined and renewed. And today, mechanical jigs produce satisfactory alignment most times, but the question is, do they achieve proper alignment each and every time? There are a number of studies which have shown that up to 30% of the cases are outliers when mechanical jigs are used. And this study showed that this occurs irrespective of surgeon's experience. And it occurs because of the limitation of the technique. We use straight rods in a broad canal or a thin rod in a large canal. There is variation in bony anatomy. And so improve the axial alignment is the crux of the matter by changing from mechanical jigs to the computer navigation jigs. The question is, has computer navigation improved the alignment? And this is a summary of literature review which shows each and every study has shown better alignment with navigation. There is meta-analysis of large number of studies, and the conclusion is that CAS lowers risk of malalignment. Also, it has been now shown that there is faster rehabilitation with the navigated knees. My experience with navigation is started in 2004 and I have done more than 2,000 cases with navigation. And our study, which will be published this year, has shown that even during the learning period, CAS improves alignment. With experience, every case is correctly aligned, each individual component is correctly aligned, and with experience, you become time even. Margin of error actually is further reduced so that larger percentage of cases are now within the range of only 1 or 2 degree of deviation. So what is correct alignment? It's not just mechanical axis, but individual femur and tibia being in the correct alignment. That we realized when we scrutinized our x-ray. This patient who had both knees done by me, the right side done many years back with conventional technique, has mechanical axis 178 degrees. But when you look at the individual component, femur is in 5 degree varus, tibia in 3 degree valgus, thus compensating each other. Whereas if you look at the side I did with navigation, correct mechanical alignment and correct individual femur and tibia aligned as well, with a horizontal joint line there and an oblique joint line here. We also then looked at the complex cases and found that however severe the deformity is, we get correct alignment time and again. Also in severe valgus cases, correctly aligned mechanical axis, correctly aligned individual components. May it be the obese patients or with a significant femoral bowing. Just as in this case, the surgeon using standard mechanical jigs put femur in significant varus, whereas on the opposite side with the similar bowing, I used computer navigation with correct alignment of both components. Extra-articular deformities, you don't need to really worry about how you will tackle this. The computer navigation will correctly place your components. So we found that in complex cases, CAS is as effective and safe, and in fact it gives you more confidence in treating these patients. There still remains some apprehensions in using CAS, particularly related to cost and learning curve. It has been shown that it is a potentially cost-effective procedure because of the decrease in the revision rate that it will bring forward. Learning curve, of course, can be shortened by soap-on practice, attending the learning centers of visitation, training the OR staff, and having the dummy runs right in the OR itself. There are some other merits of CAS, level 1 or 2 studies have shown that there is a reduction in fat embolism, systemic emboli, and cranial and cardiac emboli post-surgery. Even further, it is crucial in minimally invasive total knees, where there are higher chances of having outliers. And here, there are 2 patients, elderly, having treated with computer navigation and MIS, bilateral TKR, exhibiting on 4th day, good functional recovery, which is what we are aiming for. Lastly, remember, navigation is just a jig. One needs to master its use just as one needs to master the mechanical jigs. And I'll leave you with the last thought. Be not the first when the new is tried, but be not the last when the old is put aside. Thank you very much for your attention.